I'm Dr. Pollard. It is Women Empowerment 2022. We have a second panel here today of women who are actually experts in the field of mental health. We have a psychiatrist and we have 2 doctors of psychology. So please be prepared to ask them some questions because I know a lot of us are having a hard time getting through. We do have telehealth, which has made major accomplishments not accomplishments, but has given opportunity to people who have not been able to get help before. It has also gotten people who need help that have a difficult time getting out the door to get help, because that's an issue, to get therapy right at home. However, it's made it very difficult for the professionals to keep up with all of the demand. Okay, so that's why I brought these women here who have spent most of their day here with us. So please make sure you ask. Ask. Okay? Thank you. So ladies, can you come out please? We have Dr. Gwendolyn Green, Dr. Deepa Hasija, and we have Dr. Althea Cook.
Hi, everybody.
Hello, I want to thank you ladies so much for being here and being patient with us as we're going through our first Women Empowerment 2022. The focus is obviously mental health because my show concentrates on mental health and wellness. So again, thank you for being here. I want to start by thanking you, Dr. Hasija, for bringing the team together.
Thank you, Sandra.
Thank you. They all work at Desert Parkway Hospital, right?
I work at Desert Parkway. Dr. Green is at Desert Blue right now.
Okay.
I'm at Desert Parkway as well. Yeah.
Okay, awesome. So I'm going to need you guys to speak up.
Sure.
Because we got to make sure we get your voices on camera, okay? All right, so where do we start? If you think, most of you guys all work with children, right?
Yes, children.
Yeah.
Okay. So say I'm a mom and say, I feel like maybe diet and exercise is not helping with my child, and my child is 6. What do I do? Do I start by?
When we're assessing and determining kind of what the course of treatment would be for your kid. So I know for myself, you know, as a clinician and marriage and family therapist, the first thing I want to know is a little bit more about your family dynamic. So what's going on in the home? Has something changed? You know, reach out and find a provider that's covered so that you can go and get services. Most insurances will provide you with a provider directory that will give you names and locations of child psychiatrists, child psychologists, and people who can actually help you to get the appropriate assessments and such done. Then at that point, once they come in and they see like myself or Dr. Cook, we might decide, well, okay, this kiddo has a little bit more going on than what we would normally treat with just you know, individual therapy or family therapy. And at that point, that's when we make referrals to Dr. Hasija or a psychiatrist who can further assess and determine a pharmacological approach for the child.
Thank you. So did you want to add on to that, Dr. Cook?
Yes, so like Dr. Green mentioned, there's a lot more that goes into it. But for the basis of this question, we kind of just start with the primary care physician, and then if you need a referral, you'll go on to see a therapist or what have you. And then, like we said, medication is always a last resort, and Dr. Hasija can talk a little bit more about that. But what we do in the process is kind of trying to figure out what is going on with this kid and what services and what support the child needs. Okay, and there's a number of resources here in Las Vegas that can aid in the support that the kid they need. So we're kind of like treating the whole person, not necessarily one specific area, but trying to look at overall.
I'm sorry, I'm glad you mentioned that because I was just thinking like, okay, so your child is getting therapy, but what about the parents? A lot of times parents don't show up. And how important is it for the mother and the father, the parents, to be included in individual therapy?
Kids, they can't, they can't sign any, they're not adults, so they can't sign any paperwork. So unless they're in foster care or something like that, we do need the parents to sign off and be involved in the treatment. Like we say, you may treat the child, but they're going back home to the same family they live in, that a lot of the challenges occur. So there are different types of treatment interventions that include the family. Most treatments for kids involve the whole family. Okay, so the kid can get individual therapy as well as do therapy with the parents as well.
Okay. I just wanted to point that out because it's such an important piece to the therapy, because I've been on the other end and I've listened to parents say things like, well, why do I have to be there? Because you're a part of why they're there, period, right?
Yeah.
So I just wanted to make sure I got that out there. Dr. Nasisha, now you're the scary one. You're the one parents are afraid of because they think, you're going to mess the child's brain up with these medications because they think they can do holistic things when their brain needs something better than your mama or your grandmama's recipe that made you feel better. So how do we talk to parents about understanding that it's okay if they need a little bit of help? Because we can put on a Band-Aid, if our leg is broken, we can get it gassed, but we just won't accept that when our brain needs help, we need a little bit of medication. And we'll take a Tylenol. If I have a hangover, I don't have a problem taking a Tylenol. Yeah. But when we're talking about things we don't know, that's not on television and help, or that our mother passed on to us or whomever, you're getting into drugs that we don't know about. So that can be scary. So how do you open that conversation up with parents for them to understand that it's something necessary for the child?
So first I'm going to say that, most people have this perception that psychiatrists or child psychiatrists are there just to start medications right off bat, which is actually not true. Child psychiatrists specifically, our goal is to first talk to the child, talk to the parent, and understand what's going on. Medication is absolutely a last resort for us. So when a child comes to see me, I usually say, okay, is this a school issue first? Is this a family issue? We go back to, let me refer to the school first. Schools have counselors. That should be the first line. When kids go to school, they're at school majority of the day. So the teachers are seeing a lot of these behaviors firsthand. When they come home, they spend partly time there. So the parents are noticing things. We have to get a holistic view of things. What happened with them as terms of, are they sleeping okay? Did something change in their diet? Did something happen with grandma? Did something happen with dad that's kind of changing the system? So good history is very important in this. And the only way to get a good history is to listen to different parts of the team, which is the parents, the teacher. The child is the most important. If you sit and talk to the child and think about things from the child's perspective, a lot of your answers are right there. So when they come to me, we actually take a step back and say, let's listen first. Let's listen. Let's refer to therapy first. We'll refer to therapy for 12 weeks. We'll coordinate with therapists and get feedback. What is going on with this kid before we even consider medications? As far as child psychiatry is concerned, we do have to do that first in order to even say, we're recommending medication. because medication is the last resort. Nobody wants to put any child on medication. Sleep is very important. Sleep is a big question we ask about. How is your child sleeping? Sleep, if adults don't sleep well, we don't act right. So we can't really expect kids to act right if they're not sleeping well, or if they're not even eating well. That's a big part of it. And then feedback from the teachers is extremely important. How the kids behaving in school versus how the kids behaving at home. A lot of the story will come right from there. If someone does need medication, I'm not saying we won't start it. In some situations where the child is acting completely different, like if weeks have gone on, they're not eating, they're not sleeping, we will refer to the pediatrician first. We'll get blood work done to see if something's going on before we come to psychiatry. So things have to be ruled out absolutely before they come to psychiatry. If something is needed, or the kid is hurting themselves or hurting other people or doing something dangerous, for example, like a 7-year-old is so hyper that when the mom says, when you get out of the car, please look on both sides, and the kid's not able to do it, they're just running into traffic, doing something that dangerous, we would treat something like that. You know, we obviously don't want any child to get hurt and not treat them.
Yeah, you can go ahead and clap. So I'm gonna let you guys ask questions now because we're gonna talk about the children, but as I'm understanding, you guys deal with adults as well. And so I wanna try and get some of my therapy questions out. So let's start with the children. Any questions about children? Thank you. So, you can go to the mic, thank you.
Way back now. I'm in child welfare, so I know you guys do the acute services for our kids. And I'm just wondering, what are some of the challenges that you guys find with, you have repeat kids that keep coming back? You know, these parents don't have maybe the right insurance or anything else like that. What kind of advice would you give a parent who has those struggles with probably not having the right insurance or not having the right supportive services, like access to that? Because I know that in our city, we don't really have a lot of mental health services that really support our kids. So what are some of the advice you give those parents?
So some of the advice that I give is, I do work for DCFS as well, and they do offer, for kids who are not insured, they do offer mobile crisis services. They also offer, with some of it is in-home service, as well as therapy. We do have telehealth for them. Even medication management is actually covered free of cost for those kids. So educating, you know, the community on that we do have this resource.
And I'm going to add to that what Dr. Passage is saying, because I too work at do some stuff at DCFS as well. And one of the challenges that I see with kiddos that come into our residential treatment, and you know, they spend 6 to 9 months with us working on behaviors, working on their psychiatric concerns, and then we discharge them and go home. One of the biggest challenges that we see is that there's no continuity in the home. So a lot of the things that the child has learned while they've gone through treatment kind of starts to fall off when they get home because, you know, maybe mom and dad are too busy to, you know, do the redirections that we teach, or to hold the youth accountable, or to actually go in and make sure that they made their beds and done their chores and everything like that. So one of the things I always try to impress upon the families as we discharge a youth back into the home, I try to give them things and tools that they can use in the home so that they can continue to see those behaviors that we saw in treatment with the youth when they get back into the home. You know, it feels more familiar for the youth, right? Because they've spent 6 to 9 months learning these skills, learning how to be responsible, learning how to be respectful, learning coping skills so that maybe they're not self-harming when they get upset or they get really sad. And so, you know, one of the things we want to make sure happens is that the parents have those tools that they can use with their youth in the home.
Well, I know that Desert, like Oasis used to do that, and you guys have taken over for Oasis. Oasis has moved over to Desert Willow now, right? Or Desert Parkway, not Desert Parkway, but
Yeah,
is it, right? Desert.
so there's been a
So
transition.
they used to do that with parents and do that training with them throughout the time that the child is there. Is that happening there now?
Yes, and so what you're referring to is within the state of Nevada, because we do have challenges with our mental health services that are available for our kids, but we do have 3 behavioral issues get help with their psychiatric issues. And so the one in Southern Nevada was named Oasis, and that's exactly what we did. A big piece of it was really that parent education and parent training that we did as a part of the component of the program. That particular PRTF is demising, and everything is transitioning over to Desert Willow Treatment Center, which is the only state-run psychiatric facility for youth 12 to 17 years old. And so still, a big part of that program is that we're meeting with the parents every week, and we're talking about the behavioral changes that we see with the kid while they're in treatment, and we're talking to the parents about what they're doing. Are they working on themselves, right? Because sometimes, mommy and daddy got some things going on too that they need to get some help on. So we want to try to make sure that they have access to the appropriate resources so that they're doing some work too while we have the kiddo in treatment doing some work, right? Because it doesn't help to send them back to a dysfunctional system. Because no matter how many skills we give them, if you put them back into a dysfunctional system, there's going to be room for failure. But to your question, yes, we still do parent training. We work very closely with the parents. They're expected to participate in weekly family therapy sessions. They're expected to call their child and talk to their child on a daily basis, right? Just because they're in treatment with other people doesn't mean that alleviates you of your responsibility of parents. So we try to keep the parents very much engaged in treatment.
I wanted to add a little bit too. So with all these things that we're talking about, it's really important that there's patience in this process. There's no one treatment that fits all. All families are dysfunctional, and it's a whole process. So, the aftercare services that are provided to the family should definitely be taken serious and continued care after that point. Because just for the child being in a facility is not going to fix, or it's not fixing type of situation. It's just trying to help the child get some skills that can help them, okay? And then this is going to be like a lifelong. When I do discharge planning, I try and address families like, this is something, these skills we want you to incorporate, really for the rest of your life. You're gonna need them, right? And so it just takes patience in the process and, like a lifelong commitment to it.
Okay. I just have a quick question about kind of how certain services are integrated with the education system. When you had said earlier about how you want to hear what's happening at home and what's happening in school. And what I've been hearing is that you guys are directly kind of connecting with parents in each other, right? So is there like kind of a strong kind of bridge between the teachers being well equipped and qualified on that like clinician level in order to handle certain situations? Just like curious as to if we have kind of towards more, so training the teachers in that way, or even having it be a part of the training. And the teacher, I'm not sure, so I wanted to hear if that is something that's being done.
I believe that is started up in our school system, that there is a lot of training on mental health. In the younger ages, elementary level, a lot of training is done on ADHD. On the older levels, there's a lot of talks on suicide, how to look out for the signs of suicide, depression, if someone is cutting, if they have marks on them. So the system, the teachers are more aware now, and they are more trained on it. I'm not sure how many hours they do per year, but I know for sure they are trained on behavioral issues and depression, anxiety, how to look out for signs of suicide, or if there's a very significant change in behavior, they do reach out to the parents and see what's going on. As far as psychiatry is concerned, child psychiatry, if the parent signs a release of information, we do contact the school, and the school counselor does give us information on how the kid is doing in school. There's also IEP programs where you can say, I want a therapist to go to the school. I want them to observe the behavior in school and also observe the behavior at home. And some agencies are doing that.
Thank you. We have a question over here.
Yes. What would you suggest for the tired parent who has exercised talking to the medical doctor, has gone to a therapy referral, has put their child in with a therapist, and then they turned out to be the kind of therapist that just listens and doesn't have any suggestion, and you don't realize until you sit here at the Women's Empowerment panel that that's what you're experiencing. And there is no help from the school because the main abuser was the school. The counselor that you asked to speak with never called you back, and now your child's homeschooled. Where would you suggest that person, that's me, to start?
I would say that, that's an extremely hard position to be in. And to be honest, I hear that a lot from a lot of parents. So we did dig a little deeper, and the issue is our community is strained for resources. The school is also extremely overwhelmed. The teachers have a lot of responsibility, and teachers are a lot of them are extremely good. The counselors are good, but they're spread too thin. Okay? And if someone is tired, it's an issue that's become more prevalent right now, especially with COVID times, because the child is at home. A single parent can't really go to work if the child's very young. Someone has to monitor that kid being online. So a lot of single family moms have actually had to quit work and be home just so that their kid can attend the online classes. So I think in general, all of us, everyone is struggling. It's a very bad situation. I would say, friends, family, people who can be positive and support you, reach out for that help. I'm struggling with this.
I'm looking at it because that's my niece.
Yeah. I would say, reach out to your family member and say, I'm struggling. And they might say, well, I'm struggling too. I can't help you. Find someone that you can get together with. I have realized, especially in this pandemic, that people do want to help because everyone's come into the same boat almost. We're needing each other. As humans, we realize we are vulnerable during this time and we need each other. So to reach out for that help. And if you do need to take it to a level where someone is really needing help, take it to psychiatry. Let that kid talk to somebody. Unfortunately, the resources in this community are limited. I do realize that working in this community, talk to friends. I would say there are people out there. You just have to tell them, I need help.
And I'm sorry. I was going to say, Mom, I would add to that. It's okay to take a breath. Don't forget about your own self-care. And just with regard to, you said took them to a clinician and all they did was, the very Rogerian, just the talk therapy, tell me about your day kind of thing. So, especially when you're dealing with your kid, you want to make sure you research as much as you can the person that you're taking your child to go see. So try to see what kind of expertise this person says they have, or what type of population they're accustomed to working with, right? Is this a person that just primarily treats adults, but they see a kid here and there, or is their practice primarily geared towards treating children? Because that's going to make a difference as well when you start to look at the modalities that are used to approach the care of your child, right? And then two, as a parent, be very involved in the care, expect to see a treatment plan. You want to know, okay, what are you going to do to help my child with these specific concerns that I've brought to you? what I try to do in my practice is when you come in as a parent, my first session is with you. I want to meet with the parents. I want to know what your concerns are. I want to know what you've seen.
Without the child?
Yes.
Yeah.
Absolutely. Yeah. Yeah, because I want you to be able to speak freely. I want you to be able to exhale, get it all off your chest, and let me know what a lot of your primary concerns are. And then the next session, the first, depending on the age of the child, the first, the next 2 or 3 sessions is you and the child in the room, right? And then I start to wean you out of the session, and it becomes individual with me and the child. And then I might bring you in later so that we can talk about, so that your child can tell you what they've learned and what they're going to do at home. So that everybody's brought into, okay, this is the behavioral change I expect to see at home. And you can hold the child accountable, right? Because I need you to be those eyes and to be that person there, kind of reminding, kids forget. They forget from the bedroom to the kitchen, right? Oh, I was supposed to brush my teeth in between there. So, it's important. The family plays such a big role in the care of the child. And, it doesn't have to be family in the traditional sense of mom and dad. It can be your extended family, cousins, nieces, uncles, aunts, fictive kin, right? So that play uncle that comes over and takes your son out to go do cool things. Everybody, it takes a village. It really does, And so the goal is that once you start learning the skills that the therapist is teaching your child, is that you share that with everybody else. So that you say, hey, if you see him doing this, correct him.
Yeah.
And remind him what his therapist said. Because when he goes to see the therapist next week, she's going to ask, how were your behaviors? How did this go? What did you do? And hold the child accountable. So all of that plays into how effective therapy is going to actually be for a child, I think.
I wanted to add one thing too, because I worked for 5 years within the Clark County School District, and I'm not sure you guys are aware, besides the counselor in every school, there's a mental health professional there, okay? And that mental health professional, yes, in every single school. And so they're adding extra resources to things that the kid can have in each school. So when I worked for the school district, I will do self-esteem groups for girls, and I'll do a self-esteem group for the boys. Okay, as well as work with psychiatry, therapy outside of the school system, work with the IEP evaluator, work with the counselors, teachers. Like, I was that person in the school. One kid referred to me as his grandmother. So I would have those things, and sometimes kids just get bored and they just need like the support of each other. So I created these groups, and they were able to share things. Like one day in group, I had them talk about, like, they wanted to talk about their crushes. Like, I met them where they were, like we do in therapy, and I just let them be themselves. And I was kind of like, maybe, according to the kids, I was like their mother, their grandmother at the school. And then I got to know all the parents. I was literally the one that would open the gates in the mornings, a mental health professional open the gates, right? So, so in each school, there is a person like that. I think for elementary schools, you have one mental health professional. Middle and high school, there's at least 2 to 3. And they can do things to, help your kid. So that's extra support. And they can be the guiding force in what services that kid get in each school, as well as how it connects with the kids that are, hospitalized or in treatment centers. Okay? So that's something that's extra help here, and it works fabulous. It works really good.
Good to know, okay. Please go to the microphone. Sure.
My name is Ping and I work in the mental health field as well. I actually run in a outpatient clinic. So we do individual therapy, family therapy, in-home therapy. So I'm here today because Dr. Hasija, we've been work together, know each other, and I'm a big fan of her. So I'm here to support her. Also really try to understand our resources, our extraordinary women in this field, and we serve our community, we help our children and family. So I just want to add a little thing to your question. That's actually a very common struggle especially when parents bring a child in a clinic saying, okay, there's a problem, treat the child, right? Many times you don't really see the progress, and sometimes even worse, because depends the approach they utilized, and sometimes not necessarily doing wrong things, right, clinically, but you see the child's more standing up, more assertive. But assertive is effective assertiveness, right? But beginning when they practice may not really doing it correctly, you may feel more challenged. Or sometimes the therapist may even think you need to change as well. And yeah, but when you come to really to the change process, it's difficult for us, right? We feel like we did everything we could, but it's not effective, right? So in that kind of situation, my suggestion would be just really have a conversation with your therapist, schedule that, ask for that, because therapists not automatically grant that to you. It depends what kind of or training or their experience. And also sometimes you really don't see the direction, kind of is your direction, you have questions, ask for, schedule a clinical meeting with a supervisor, with a therapist, just together, I don't really see this is what I want, and how can we make this, educate me if I'm kind of have a wrong expectation or unrealistic expectation, right? So many, if you go to a clinic, they all have this structure. Supervisor, on-site supervisors, and interns have their clinical supervisors. And we have a team, treatment team. So those are resources. Many times we kind of, I notice patients or parents forget about that's an approach you can actually ask for. So those are many times, actually it's very powerful. And same as school, they have all the resources there. If you don't go there, specific ask, they not automatically come to you. Okay? But the key is how to make that effective. When you ask something, you don't really go there, blame them, or because I'm not happy, and then they take defensive approach, right? That sometimes leads to wrong direction, now which is not really what you want, right? So just this is not working, I want some attention, how can I make this push to work more effectively, right? So that's a little ending, add to all this comment is a beautiful response you give that question. Like Dr. Hasija said, that's actually very common. So I actually have another question for all of you. Since you seem like all work in the Delta Parkway, we do refer quite some teenagers to your hospital for residential treatment. Can you describe from the person got referred and come there, do the assessment, and then they got admitted in the program, and then normally sometime their discharge can be after 3 days, normally it's a week. Right now they don't really go much, right, longer than a week. That's, of course, you can explain, well, it's that reason, could be clinical, could be insurance. And also I would like to understand how our program runs, what resources integrated into the program, what this multidisciplinary team collaborate together. And once the patient discharged from the residential treatment, someone to the partial hospital program, right? Some may refer to IOP. Some may refer to the community outpatient program like us for continue their therapy and their medication if they have a medication already started. So can you just give a little description of the procedure so our public may know a little more about how that runs? Because right now, some of our providers don't really totally have a full picture about that. When they recommend their hospitalization, some parents freak out or some children felt very scared as well. But after that, after husband, they came back like, yeah, that was actually very nice, very helpful. So I like to give this opportunity for you to educate our public and us as well. Well, thank you.
Well, and I can explain a little bit about that. So when a patient comes to us, let's say from an outpatient clinic like hers is Desert Behavioral Health, or if someone sees me at my clinic, Satori Behavioral Health, if there's an issue going on which cannot be handled in the home, which means the kid is actively suicidal, they have a plan to go home and overdose on pills, cut their wrist, something extremely serious, we will refer them to the hospital. When they get to the hospital, they go through a process called intake. There is a person there that will assess the kid. Is this an issue that really needs hospitalization, or is this something that can be handled at home? If it's a safety issue where the parent has to constantly monitor the child 24/7, and they're saying, I'm not gonna sleep tonight because I'm afraid what my kid's gonna do, that's when they need a place like this. Or the child is threatening them, like, you know, when you go to sleep, I'm gonna beat you up, or I'm gonna hurt the younger child, and you don't feel safe. That's a reason why someone should be in the hospital. Or if they're using drugs, they're hearing voices, now they're talking to themselves. Those are reasons for hospitalization. When they go through the intake process, intake will be like, okay, this person really meets this criteria. They will admit them to the inpatient psychiatric floor. Inpatient psychiatry is someone staying at the hospital. Just like you would go to the medical hospital if you were not breathing well, or if someone had a stroke, they would admit there. Same thing with a hospital like this, except it's for psychiatric reasons. We're trying to maintain safety for that kid or the adult. First, they will rule out any medical causes of this. Once the medical cause is ruled out, they will determine, okay, this is purely psychiatric. We're going to admit them to the floor. On the floor, sleep is monitored, eating, habits are monitored, groups are started. They teach the kid coping skills. The psychiatrist is there to see, does this require medication management? Is some of this going to get better just by helping with medications? That will be determined in the hospital. Usually kids who come and stay at the hospital, it takes about 3 to 7 days to stabilize. Depending on the child, some may take less, some may take more. But after they're stabilized from a program like this, we step them down, which means the parent could say, well, I just want outpatient services, which is once a month or once a week therapy, which we will arrange. Or some parents may think, I need a little bit more because this kid is not currently suicidal, but still thinks about, maybe I should cut myself to relieve some anxiety. Those kind of kids will refer to the partial hospitalization program, which is usually in this town, it's about 10 days, so 2 weeks, where the child will go there from like 9 to 3, and the therapist will be there, help them with group therapy, also engage the family to establish a routine for this kid at home, and have that dialogue back and forth. Is this treatment working? We're trying to teach your kid what are their coping skills to use in a difficult time, or identify your trigger. What's your trigger? Are loud noises your trigger? Are yelling, screaming your trigger? Identifying the trigger to see, okay, what coping skill can I build on to use when I get triggered? So we will teach them that in that kind of program. Once they graduate from that program, they might decide, okay, I do want to still do this, but maybe 3 times a week, which is intensive outpatient. So I'll do this few hours in the morning or a few hours after school. I have this available to me. And if someone wants that, they can continue with that. If they don't want that, when we step them down to outpatient, which is psychiatry once a month, or psychiatry once in 3 months, depending on how that person is recommended. Medication management alone will not treat most situations. Therapy is, you need it, or this is not going to go forward?
There's a couple of LGBTQ resource centers here in Las Vegas. And if you don't have insurance, they will give you therapy once a week. You may have a different therapist on a weekly basis, but they do provide this service.
And I think someone was saying before too, it was Ogechi Musa who was saying journaling. You know, that's a good way to start your process as well. That's a cathartic process to get your headspace right until you can get some help. Okay? Yes, ma'am?
Sorry. Do I
You can just go to the mic, it's fine.
Do I take too much time to?
No, you're fine.
Well, this is a great opportunity. I didn't expect to have this opportunity to talk about this, but since Dr. Hasidra talks so very detailed about inpatient process, and two of the other doctor talk, and we relatively mention some outpatient services as well. Maybe I want to take the opportunity just to introduce a little bit about outpatient, the procedure about outpatient, how that works. So I work at Desert Behavioral Health. We are a outpatient clinic. We do have therapy and also have medication management. So what we do is we take a lot of the patient directly from Desert Parkway, from other hospital when the patient got discharged. And because that's part of the discharge plan is connect to the next step of the treatment, right? For the either medication or therapy. And like Dr. Hasidra said, therapy is very, very important. Even they already stabilized with their medication, how to continue with the medication, because when they get better, sometimes they feel, oh, I'm better, I don't need this, right? They have to understand. And also, mental health problem is very challenging, not only for ourselves, for people around us as well. So able to understand the mental health issue, and also how to cope by ourselves, how our family, loved one, to be able to understand and support as well, right? It's a big component. So when we got a referral, could be from school, could from hospital, could people, when they experience something and they just realize I need some help, so they go through an insurance company to find, to schedule, right? Or we don't really have, we have a website, but so whatever the way they find us, they make an appointment. Our first session will be assessment. So for adults, of course, they're responsible for themselves. They come in by themselves. If whoever wants to be included in their treatment, they have to give consent. They just cannot have anyone regular, people just pop in their service. But for children, like I said, have to family, they're minor. All the paperwork have to be signed by their parents, right? So that first session will be basically what's going on and the history. Then talk about who will be the suitable provider. Some family, boy maybe want a boy, maybe want a female, maybe an age, and you will be surprised sometimes young youth maybe prefer a little younger provider rather than old folks like us, but depends, right? Some old folks definitely don't want to see a 20 years old therapist. They want to see some more mature. So now we kind of transfer that one to their training, there's needs, match them up, right? Refer them to we call assigned therapist. But we always tell the patient or family or client, if you call, you have a freedom of choice of a therapist.
Right.
Yeah, sometimes work out, sometimes don't work out. Don't work out, you can't.
Get it out.
Yeah.
But I just want to interject really
Yeah.
quick and say that you can contact your insurance and say, I'm looking for a Black young therapist. You can say what you want. You don't have to just take what's given to you.
Not necessary.
You have insurance.
Not
I called
necessary.
my insurance company and I told them I'm looking for a Black female therapist. And they're able to go in and find them all around Las Vegas and give me those providers. So you can do the same.
Not necessarily insurance gonna be able to directly sign the exact the right one. I guess being race or male, female, insurance does have that information, and sometimes not even, because those information, especially race, or they may have more information about their educational background or expertise, not necessarily their race or age. So insurance might not really able to provide you the best suitable, but once you come into a clinic, and especially a clinic have multiple providers, not just one or two. So you have more likely not only choose the one with the age, with the race, cultural background, language, also with their expertise, their training. So it's so that's the first step. Then once you sign to a therapist, then you really work with the family about this treatment plan. What you come here for, what you want, what's the priority, what's the right secondary. So you're able to, when you treat children, the treatment planning is, the parents must be included. Including the treatment plan have to be signed by the guardians or parents. So they know where we're going. At least we have a map. And every 90 days, that treatment plan needs to be reviewed and upgraded. What's progress made on this goal 1, 2, 3, and what really not moving? Is that a bad goal, or is a new thing come up? Right. So you really, the parents have to be in, at minimum, have to be inside in those process, and then sign off with the treatment plan. Be aware what really your therapist or your children, doing, and able to provide feedback. There's made progress or not. So, and hopefully, well, their treatment plan also depends how the intensity. I just had a Chinese family, traditional Chinese family, especially older Chinese moms don't recognize this or depression or mental illness. Then that's just a lazy kids, just bad kids, just a liar.
Yeah.
Okay, that's the name you call. We use a different terminology, but we describe the same thing. Right? And the child, you think, a threat, just by, I'm gonna kill myself, and they want something. Okay, that's still doesn't mean that's not a problem, right? That's still a behavioral problem. Normal person or healthy person don't use that way to get what they want, right? I'm here to teach your child and help the family, how the child can get what you want, is that right thing to be want, right? To want, and how to get it in an appropriate, healthy way, safe way. So it's a lot of parents actually teaching involved, in psychoeducation involved. And then the parents only pay so many times. I don't want to come every week. I cannot drive, whatever. I said, you choose to work with me, and for her condition, twice a week or once a month, that's or 1 time 2 weeks, it doesn't work. Have to be more intense. At minimum, have to be weekly, right? So you come in, I come in. That is the condition, and so you cannot, because you are not able to, right? You fail, and there's a problem. You bring in, you have to respect my expertise. So first, I not necessarily have to so straightforward, but there's certain way of this must need to be done, right? If you respect me as a professional, right, in the field for so long, and you come to looking for help, and you cannot be the driver all the time. So, well, it's a lot of skill to utilize to push and pull. You don't want to push them off a cliff, but you have to pull them back. So I'm seeing this is a normal procedure. When you have a child involved with the therapy, you want that treatment is such a key, right? Minimum every 90 days you want to be involved, and hopefully it can be more. But there's also, you don't want to be every single time the parents step in. And we see that too, and become a parent's session and not the child one. And tell me what my child said about me. right?
Oh, yeah,
That's another common challenge. And then that's probably a major reason that child have a problem as well. So there's a lot of family therapy can involve. So it's difficult, complicated procedure. Anyway, so our goal is able to move forward until come to the point, okay, all the goals are achieved, we're 85–90%. Right? And sometimes they just feel so comfortable, they don't want to go away. And then you have to encourage them they want to continue coming once a week. And then you say, oh, let's try right? Once 2 weeks, then once a month, then once a quarter. So and then depends what kind of condition. I have a patient with schizophrenia. I never want to totally discharge them. We want them at least once a month, once a quarter, check in, make sure all the medications comply, right? There's no major stress, their welfare paper filled up, and they continue to receive their SSI, right? All those are very important. You don't just like, okay, I'm done, you carb. Certain things just never really gonna be, you have to just maintain that. So this is what really outpatient do and how that flows. And by understanding the procedure, you can see where I can interfere, where I can step in to make that effectively, make that work, right? Otherwise, it can be very, very overwhelming. Of course, sometimes when their crisis come up, there's step up services. So it's a flow, in and out. It's a whole flow procedure. And well, thank you for the time.
Absolutely. I guess I should have
I just want to add what she said, so I appreciate her. She's literally giving you the real holistic approach to how clinics help our clients. So that's really important. I think one thing she said, and this brings a lot of the misunderstandings from what mental health has to offer, is sometimes parents don't know the questions to ask. You don't know what we really do, you just don't know. You see all these people when you go to the clinics and the hospitals and you're like, are they really helping my kid and stuff? So don't feel afraid to ask questions, don't feel afraid. It looks like when you come to the clinics and the hospitals, we're really busy, but we're not that busy to stop and answer your questions. We're never ever too busy to do that. Okay, if you have, your questions are important. I mean, and if we have to explain the whole process over and over again, we will do that. Okay, we will do that.
Okay. Who deals with the adults? Marriage, family? All right, here we go. Any questions about relationships?
I have a question about relationships, in general. Yeah, sorry, I know you understand. So I have a question about diagnosis, and especially with nowadays, with 2022, mental health is in the limelight, right? And I'm curious, even with children and young adults and older adults, like diagnosing, like that whole process, how, because I mean, I think officially there's not like a clear test to be given to say, oh, that's an anxious brain, oh, that's a depressed brain. Like how is that process? You know, like how do you deal with it being more so like, what is it, the placebo effect? Like how you might be imposing these symptoms because it's so much out here, you know, and you might just fall into this behavior and diagnose yourself in a way. I don't know if you understand what I mean, but like how, you know, like how can you, how have you encountered that before, or how can we combat that? Like how do we know when it's the diagnosis, I guess?
Stay off the internet.
Yeah.
No Dr. Google. Yeah.
Oh, that was the answer.
So we do get, so when you're diagnosed, we just don't get these diagnoses from what we think. We actually are trained and we go through a number of classes to work up to that point where you can diagnose. But we actually use the DSM. It is like a book that we look at, and that's where all the diagnoses are in the book, and we get it from there. But there's a number of things that go into diagnosing, like culture is considered, a lot of your history is considered. There's a lot of different things that kind of go into diagnosing.
Yeah.
So
You have to look at the whole picture. I think that, history is very important. Some people might have a genetic condition contributing to them being a certain way. So we look into that. A lot of it, if it's just situational, that's not really a diagnosis. That's more like an adjustment period for someone. If someone passed away and someone's grieving, they're stressed out for a long time, that's not a diagnosis. It's like it's a hard period, they're grieving. A diagnosis is something that impairs you functionally on a daily level, meaning it causes problems with your relationships, with your work, with your health. That would be a diagnosis that a clinician would work up to. So a careful history, I would say, is very important, even saying someone has a diagnosis. So we don't throw that out randomly. If, for example, during the COVID time, a lot of people got very depressed and anxious at home, but they may not necessarily have a diagnosis. Now, if they're laying in bed, they're crying all the time, and it's been going on for months, they're not able to get up, take a shower, they're not eating, they're so depressed that they don't want to go to the kitchen to even make a sandwich. We look into that and explore that a lot more before we say, okay, you have major depression right now. So it does have to be explored in detail, the contributing factors to it.
And there are also certain assessments that we can do as well that kind of help us in guiding us towards a diagnosis for you. So there's things like the Beck Depression Inventory, which is a self-reported skill that we can give to you to kind of determine whether or not you might be dealing with depression. There's anxiety skills that we can give also. For me, primarily, when a patient comes in and I'm assessing them for a diagnosis, I look at three things specifically: the frequency of the symptoms, the intensity of the symptoms, and the duration of the symptoms. So what are you experiencing? How long? How much is it impacting you? So the way Dr. C just said, you might not want to get out of bed, you might not be eating, but is this just like a one-day thing because you're hungover, so you laid in bed all day and you didn't eat dinner, or is this something that's been going on for weeks on end, and now, we've got the frequency, we've got the intensity, we've got the duration, so we can give you a diagnosis of depression. So a whole lot of things go into it. I know sometimes it just seems like, everywhere I go, they say I'm bipolar or that I have borderline. And it's because you're exhibiting certain symptoms, you're meeting the duration for those symptoms, the intensity for those symptoms, and that's why you might keep getting that diagnosis. So at some point you might want to sit down and, that might be it.
Someone was saying before, they were like, I don't know which ice cream I want. I don't know if I want chocolate or vanilla. And the friend says, you're so bipolar. So yeah.
That's not bipolar.
So if we can get into marriage now. Okay, so I have learned through doing this program that couples counseling is super important, but first you need to deal with you. So before I can go to therapy with my husband, I have to first understand what I'm doing, right? So if I were to go to therapy first without working on myself, you better believe I'm going to be sitting there blaming him for everything because I'm right? So, and vice versa. So it's super important to make sure that you're dealing with your stuff first so that you can be present for that other person to see change. Okay? So do we have any questions? Maybe my husband has something to say.
Let's see. support your wife in her events and endeavors?
Show up.
Supporting somebody who needs to getting answers and trying to work through their situation. Sometimes it's just being present
And listening.
and listening. Yeah. I mean, I had a friend, she wanted to talk to her boyfriend about a difficult topic, and I just said, you know, what's his favorite meal? She was like, yeah, I think if I cook that, he'll listen, and it worked. So all things, you don't need to go to a therapist, you know, for everything. Some things you kind of like, just kind of figure out what helps you connect with the other person, can help you have a good conversation or, you know, talk about some difficult things. I mean, sometimes some things are just simple.
Another thing I would add to that too is, for some, you have to check your ego at the door, right? I know with this pandemic, it's driven a lot of people into being entrepreneurs and starting their own businesses, you know, whether it's they're doing hair, you know, or they've come up with some skincare product. And, you know, in the relationship, now the more dominant figure in the relationship is starting to feel challenged, right? Like, oh, what do you think you are because you got these little followers on? And doing this, and now, you know, you too good to go to Raising Cane's with me. We gotta go to, you know, go to chow or something. So, you know, in those cases, you really want to take a look at yourself, right? And find out what's triggering me to feel this way, you know, where passive aggressive, right? I'm happy for you, but I ain't really happy for you. Or don't let your head get too big, or don't forget where you came from. You know, we hear that one a lot, right? Don't forget where you came from. Well, what does that mean, you know? So if you're really trying to support your spouse or your partner or whoever it is that's endeavoring on something, you know, it's really about being in a good space with yourself so that you can truly feel happy for them and feel supported for them and be able to give, you know, those pieces of you that they're going to need as they're trying to move forward with whatever it is they're attempting to pursue.
Thank you. So I do want to revisit something. I want to revisit that you have the choice when it comes to who you want to be your therapist. And as I said, one of my requirements was in starting that I had to have a black female for me. Then I realized I don't need a black female. I just need somebody who knows what they're doing. But if the process to get what you need starts with a black woman, let's say, because I hear that a lot in Las Vegas, I'm looking for a black therapist. There are many here. Here's two. You know, two showed up today. There are women of color here who are able to help. And I know they can be tough to find. But as I said, you can ask your insurance provider, and they will do a search for you. And they do let you ask by race if that's your choice. But please understand, your help may not be in the same culture or the same color, okay? And you have the choice to ditch one and get another one as well.
It's sometimes good, sometimes really good you have someone that not from your culture. I have some clients that, you can clearly tell, right? I'm not a black woman, I'm not a white woman. I'm everything. So I wasn't born in this country as well. So I got my majority of my education in China, and I came here to continue more education. I lived here for over 20 years. So who I am, I feel I'm a mix of everything. That's how I see myself. So of course, when I come in, I speak Chinglish. If you don't understand, don't be surprised because it's a different language. So really? That's a joke, but anyway, so it's because you see, we talk about my hands, right?
right? From your perspective, you see exactly what you see. From my perspective, what I see, they both true.
Right.
But sometimes therapists really bring our clients able to see both sides and able to have that freedom to view things in a holistic way. And not only consider me, also consider other, but not only consider other, also there's me, right? Finding that balance, everything is about the balance. So, and I think some of the Eastern wisdom, right, especially nowadays in therapy talk so much about mindfulness. That's the root actually from the Eastern culture. And the Western, being independent, right, being 18, you can move out of the house. When I talked to my mom about my son being 17 and go work in a fast food store, right, high schooler, making some money to pay her own gas. My mom said, why do you do that? Do you need money? He should study. He should go to some college. And I have to really, you see the differences. I said, that's a popular thing. Be proud of being 17, able to work, make money for themselves. It's not because we really I don't have the money to. But the Chinese, when I went to school, when I was in school in China, I went to school 7, I got home 7, eat dinner, continue to do my homework, everything until 11 or 12. That's our norm, right? So culture-wise, where you find your niche. So that's what I'm saying, we're back to the topic. And you're able to find someone different, right? It's so much just like open door. You really don't know what you're gonna see, but you will find something. That openness is part of the mental health component, I believe. So don't be hesitate. If they assign me to you, don't just say no because I'm not black. All right, thank you.
I'm saying when you're seeking for something that you want, you can do that. Okay.
Right, and because there is still such a big stigma with regard to mental health in our underserved population, and just some of the fear that some of us have about, when you look at, not necessarily mental health, but when you just look at healthcare issues, across the times and just things that happen to certain populations that didn't happen to other populations, test here, test there, there's a lot of apprehension, right? A lot of apprehensiveness about going to sit before a person who doesn't necessarily look like you and that you may think might not be able to bond with you in a way where they understand some of your background and where you're coming from with certain things. So if it feels more important to you to have somebody who looks like you that's sitting across from you to get you into therapy and get you into that level of care, then please, seek that person out. But do realize, the person sitting next to you that don't look like you may be just as great, maybe even better in helping you through whatever your particular situation is.
Hi, I'm really happy to be here. I just want to say that. I came all the way from Maine. Yeah. And I heard about this conference, and it was very nice to when it comes to mental therapy and referrals to the insurance companies, when you guys bill, what is the EAP program? Like, say you get a referral from Cigna, and you get an email saying that you're an 18-year-old female, for regular counseling. Is that considered a specific code through EAP? I guess where do we decide, when do we know if it's EAP versus just a regular referral?
And what is EAP? What is that?
I'm sorry.
Employee assistance program.
The EAP is an employee assistance program that a lot of employers offer that gives you access to a number of mental health sessions, therapy sessions that are actually covered by your employer. So it doesn't even have anything to do necessarily with your insurance. But generally, what I've seen happen, at least for me, is just like you said, I'll get that email from Cigna, oh, we have this person, they want to use their EAP plan, she's 18 years old, she's suffering from depression, let us know when your next available slot is, right? And so I respond. And then normally what happens is if Cigna's approving it and, I say I have a spot open and Cigna's okay with it, they'll normally provide me with a billing code that I utilize, I put into their system, or I put it on the C1500, the CMS 1500, which is the paper form that we use to reimburse back. And I'll put that code in there, and the dates of the session, how long those sessions ran. Sometimes they'll come back and ask for just kind of a clinical update, like, are they doing better? Do you think they're gonna need more sessions? So that they can give an additional approval. But generally, yeah, everything's a code usually with insurance, and so, you know, if we're not billing the right code, then we don't get paid as clinicians, but, you know, you got your service, and so that's the important piece, right? Did you get what you needed when you came in to see us?
Well, sorry, I should be invited in the front, right?
Right. You want at the table.
Because our clinic take EAP as well, the EAP is generally from what we do. Well, I want to look at you because I'm talking to you. Yeah, and so the EAP, like you said, the employee assistance program that paid by your employer, that's part of the benefit. That can be yourself, can be your family, and can be any issue. Doesn't really have to be a clinical billable CPA code. So if you have some conflict or difficult conversation with your employer, then you can come in, talk. Because when we bill, we really don't have to put a code, CPA code there. We just basically go to their website. Of course, it depends who run which insurance, which program, right? But currently, we take the HPN one and also the HUC one. So pretty much we just go to their website, seeing because they already approved normally 5-6 sessions a year without a copay. You just come in, and we will see what's the issue we address. Could be a family issue, could be a employee, right, work. No restriction about what EAP can support. It's a variety.
And I don't get a follow-up, so I don't know, like, if these patients that I am working with are EAP or not, because Cigna doesn't reach out to me and say, okay, these are, you know, this is the person that you decided to sign up with you. Like, I don't know, like, there's no follow-up, like you mentioned. Like, there's some sort of follow-up, so I don't even know.
It's usually the client will call you. So they'll go back to the client and tell the client, oh yeah, well, this particular therapist says they have a date open, you know, this Saturday at 2. And then they give that person your information, and then they leave it to them to call you and confirm.
Is that, so are you also a therapist?
Yeah.
So what happens is, if you are fortunate enough to have multi-credentialing packages with different providers, right? And so you happen to also be an EAP provider and a licensed outpatient therapist.
Right.
What you have to do, you have to identify with the home office who was ever checking the patients in so that you know that the EAP stops after how many sessions. Because number of sessions are determined by the employer. So you could make your front office to make a cheat sheet for you so that before you can do it yourself, you want to find out how many EAP sessions are authorized, and then after that number of sessions are authorized, then technically you should have a different patient form, because now they're saying you can disclose their mental health conditions to the insurance or billable code. When they come into EAP, traditionally you're not supposed to disclose any mental health diagnosis because it's EAP only, it's confidential, it's non-billable mental health.
We have one question.
I'm glad all of you ladies that are doing a wonderful job. But my question is, I like the movie portion. My question is, what's the best way to approach your spouse, in my case my wife, if I know that we need therapy? Would it offend her if I say we have to go? Or would you have any idea, I'll be slowly how to, you know, kind of pet her? That's my question, or just say it straight out that we need to go to therapy.
Well,
That's a great question.
of course, they be as soft and kind when it have timing is everything. You know, timing is everything. And to have that conversation.
Thank you.
I don't think there's it's not really one way that you can do that. Just like timing and place is everything.
Okay, thank you.
I'm glad you're here, Carlito.
I gotta go out there.
Yeah,
Ready?
yeah, thank you.
All right.
Great question, that is a wonderful question. So I don't know who needs to hear that, but,
Oh, I'll add one more thing to that.
Sure.
I'm sorry that he left. So remember, if you was to ever go to therapy for couples counseling, remember you're going to therapy, although you're a couple, you're still going to therapy for yourself. Okay, that's a good approach to take. Because lots of times couples will start therapy together, but they won't finish, right? So the ultimate goal is that you're coming to therapy, you want to share the whole experience and work on issues with another person, but you're ultimately there for yourself. That way that you gain insight and awareness to how you relate to the other person, not how the other person necessarily relates to you. You can get into that point, but just remember you're going for yourself.
so I want to thank you ladies again for being here. Miss Gwendolyn Green, or excuse me, Dr. Gwendolyn Green, Dr. Hasija, and Dr. Cook, Althea Cook. Thank you so much for being here, taking time out of your day. Thank you again.
Thank you.
And I also want to give a special thanks to Mark Thomas of Sluggin, the magazine, who is our proud sponsor of this event, and It's Where I Am. Also a special shout out to Kelly. I don't know her last name, but she is a part of the magazine as well. And I want to thank her for being here personally to attend this conference. Also want to give a shout out to family and friends who are in support of this. And I also want to give a special super duper thanks to all of the supporters from all across the nation for this Women Empowerment Conference. Thank you for donating tickets for women to be a part of this. And if they didn't catch it here live, we will have it recorded and available to them in the future. All right? So thank you. I was Audra Pollard. It's Where I Am.